Hello, everyone. Welcome to Apollo Med Flight's Training Academy. Again, my name is Matthew Adams. I'm the clinical manager for Apollo Med Flight, and in this specific presentation, we're going to be talking about flight physiology and how it relates to the disease processes that may affect us during transport. All right, we got a little. There we go. Okay, we had a little freeze up there. So with the King Airs that we have on our platform, we have the King Air 200, which is the aircraft there on the left-hand side of the picture, which is has more horsepower, has that whale-tail type appearance there. And then, of course, we have the King Air E and C90, which is the C90 up there on the right-hand side of the picture, has that fishtail type appearance. The King Air 200s are better suited for long-distance transports. However, both are capable of doing such missions. So let's get right into the objectives here. We're going to discuss the history of air medical transport. We're going to identify the basic principles of flight, discuss the atmospheric pressure and how it relates to flight. Of course, we're going to discuss the major gas loss and the purpose of flight physiology. And then, of course, identify key components of oxygen and use at altitude. Then we're going to discuss the effects of altitude on body systems and associated signs and symptoms. And then we're going to manage disease processes related to flight. Now, with the history of flight medicine, it's very interesting on how the humble beginnings began with all this. Of course, the ambulance systems first established in the 1400s to transport war casualties. And then in 1910, the U.S. Army officers at Fort Rankins, Florida, modified a biplane to carry a litter patient. Then in World War I in 1915 was the evacuation of the first wounded soldier. Then in between 1936 and 1938, during the Spanish Civil War, the war casualties in unpressurized junkers over a 1,600-mile route were transported in altitudes greater than 18,000 feet without serious complications. So that is simply amazing, specifically on how everything has become so modern and where we are today. And on April 23rd, 1944, in the jungles of Malu, Burma, the first U.S. soldier flown to a field hospital by helicopter. Now, in the Korean War in '53, over 300,011 patients were airlifted to hospitals. And in 1967, the first U.S. commercial flight program started by a Superior Ambulance Service in Westland, Michigan. And then in 1973, as we conclude on the history, the Vietnam War ended and over 500,000 patients were flown. So a little factoid there as a tidbit. Now, I want to get into the justification for flight services, okay? What we want to do is to expedite transport and care to tertiary care facilities and specific trauma centers, depending on what type of critical or trauma patient that we may be dealing with. And of course, accessing or patients that we need to extricate specifically for our rotor platforms. However, we are able to have scene flights in our fixed-wing platforms if the local EMS agency has a local airport nearby. Then, of course, delivering the critical transport team to the critically ill or injured patient is the ultimate goal in our industry. So I want to talk about the basic principles of flight, which include many elementary physics concepts, okay? Lots of physics to discuss. And these can be easily identified by the structure of the aircraft. Now, there are four major forces of flight. Lift is caused by the variation in air, okay? Lift is caused by that variation in air when air flows under and over an airplane's wings. It's opposed by weight, or the force of gravity. It's going to pull it downward. Then thrust is caused by the action of the propellers moving the plane forward. So opposed to that is drag, which is caused by the air resistance. If lift is more than weight, the plane will rise. If thrust is more than drag, the plane will slowly accelerate. So the airplane wings are designed to take advantage of lift. They're shaped so that air has to travel farther over the top of the wing than underneath it. Okay, so with the science of lift, the airplane's wings are designed to take advantage of lift. They're shaped so that the air has to travel farther over the top of the wing than underneath it. The reason for this is what they call, I believe it's called Bernoulli's principle, which states that an increase in the speed of the air or any fluid results in a decrease in pressure. So when the air has to travel farther over the top of the airplane wing, it must also travel faster, which results in lower pressure. So the shorter the distance of the wings resulting in higher pressure, it's going to cause the airplane to move upward, okay? Now we're going to get into some atmospheric pressure here. Atmospheric pressure simply is in a mixture of gases. We're talking about the components of the atmosphere. the components of the partial pressures of the atmosphere. In a mixture of gases, each gas has a partial pressure, which is hypothetical pressure of that gas if it alone occupied the volume of the mixture at the same temperature. So in other words, the total pressure of an ideal gas mixture is the sum of the partial pressures of each individual gas in the mixture. Okay, as we see, the prevalent gas is nitrogen, as well as oxygen being 21%, then the other remaining miscellaneous pressures. So hypothetically, the partial pressure of gas, to put it another way, is that specific gas wants to occupy the pressure alone in isolation. Okay, that's why they call it a specific partial pressure. Now with atmospheric pressure is caused by the weight of the atmosphere. So at sea level, it has a mean value of 1 atmosphere, but reduces with increasing altitude. So in other words, at sea level, the atmospheric pressure, also called barometric pressure, is higher, and as altitude increases, that barometric pressure is going to decrease. So it has an inverse relationship to it. Now this is important when we start talking about gas laws, specifically the 5 that I have listed here. Okay, so the body's going to respond to changes in barometric pressures and temperature, volume, and so forth. So let's get into the discussion about Boyle's law. Okay, with Boyle's law, what we remember about Boyle's law, as altitude increases, gases are going to expand, and as altitude decreases, gases are going to contract or shrink, if you will. Okay, and this can affect many, many body systems, as we'll talk about that, as well as some of our equipment. Let's talk about how it affects the equipment. So remember that the barometric pressure is going to decrease, which is going to cause when we're increasing the altitude. So this is going to affect specifically hollow components, such as an ET tube cup, that we want to make sure that we have a ET tube cup later and monitoring those pressures there. And that'll be a part of the training in the practical aspect of it. Of course, mass pants will expand upon altitude increasing, which I don't think of an industry that currently uses those. So we want to make sure that we're using an NG tube and it's vented, specifically in those patients who have any sort of gastric issues. Of course, chest tubes, we want to make sure that we do a specific look at a chest x-ray before departure on a patient. If a patient has a pneumo greater than 20%, as we identify in the chest x-ray, we're certainly going to want to make sure that we place a chest tube. Of course, balloon pumps, as they purge during during ascent, of course, ventricular assist devices, and then vacuum air splints. Typically what we'd want to do there is you want to bivent those vacuum splints or air splints, or even the fiberglass ones. That way we can allow for complete expansion during ascent. Now with Henry's law is basically a gas law that states the amount of dissolved gas is proportional to its partial pressure in the gas phase. So an example of where Henry's law is at play is a depth-dependent dissolution of oxygen and nitrogen in the blood, especially as we would see that in an underwater diver. Okay, that's going to change the pressure during decompression, which would lead to decompression sicknesses because of the nitrogen bubble formation there. So basically it explains the hypoxia experience with increasing altitude as well. The pressure of the gas is reduced with ascent, the amount of gas dissolved in that solution decreases, and that's what's going to lead to the bubble formation. So an everyday example that we can give on Henry's law is given one by drinking a carbonated beverage, okay, which contains dissolved carbon dioxide. Before opening, the gas above the drink in its container is almost pure carbon dioxide. And it's at a pressure higher than the atmospheric pressure. So after the bottle is opened, this gas is going to escape, which is going to move the pressure of the carbon dioxide above the liquid to be much lower, which is going to result in gassing as the dissolved carbon dioxide comes out of the solution. Now, with Charles' law is different from Boyle's law in that it gives the relationship between the volume and temperature in an ideal gas where the pressure is constant. So Charles' law states that if a temperature of a gas increases, then the volume increases, and the opposite is true. Okay, the temperature is going to go down, the volume is going to go down, and so forth. So if you imagine a balloon filled with helium on a cold winter day, while you step outside, while you are inside of a normal room temperature facility, that's going to be normal, that balloon will be normal. But as you step outside into that colder environment, it's going to cause that balloon to shrivel up. Okay, this happens because of the temperature of the helium in that balloon decreases and becomes less dense. okay? The helium is losing the particles and the energy becomes more concentrated, decreasing that volume. And this is also, and how this applies to our specific industry would be oxygen bottles, okay? As the atmosphere is colder, you're going to see a decrease in the pressure as the temperature drops, okay? And of course, the opposite would be true, is we're going to see an increase in temperature. As we see an increase in temperature, you're going to see an increase in pressure. And this is true because as the altitude increases, the temperature becomes cooler and also becomes drier as well. Now with Dalton's law, lots to say on Dalton's law here. Dalton's law, also called Dalton's gang or Dalton's partial pressures, and it states that a mixture of non-reacting gases, the total pressure exerted is equal to the sum of the partial pressures of the individual gases. So let me simplify this for us for a little bit. If you've heard of a therapeutic oxygen tent, you are seeing Dalton's law of partial pressure put to work. Simply put, all the gases in the Earth's atmosphere exert individual pressures that add up to roughly 14.7 pounds per square inch. So you change the concentration of the air gases, for example, making it more oxygen rich, and you increase the pressure and amount of oxygen delivered to a patient with diminished lung capacity. So by increasing the percentage of any gas in an air's mixture, a higher partial pressure of that gas can be achieved, which is the basis of oxygen therapy. Dalton's law is used in the practices of pulmonary physiology, ventilator care, medical gas administration, arterial blood gas sampling, pulmonary pathophysiology, and among other applications. A specific example I can give you is the FiO2, the oxygen blended with the air. So if we have a specific patient that requires a specific FiO2, we're going to take the FiO2 that's currently known, such maybe 21%, and multiply that by the current atmospheric pressure, which would be at sea level. Typically in the Panhandle and the plains of Texas is at 760. So we'll multiply that and then take that value and divide it by the altitude of where you're going. So if I had 21% and multiply that at 760 roughly, doing math in my head, take that and divide that by the altitude where you're going, which maybe we're going at 8,000 feet, which would be 565, 85 millimeters of mercury, which is roughly going to give us about a 48% FiO2. And so it's very important when we're talking about patients with maybe specifically those pediatrics who have congenital heart disease, okay? You don't want to over-oxygenate or under-oxygenate those patients. Now, Graham's law is a gas law, which relates to the rate of diffusion or effusion, okay? Which basically we're talking about gases diffusing or migrating from a region of higher concentration to a region of lower concentration until that equilibrium is met, okay? So Graham's law may only be used to compare the rate of diffusion or effusion of gases at constant temperatures. So like other gas laws, when the concentration of gases becomes very high, the temperatures are also going to be high as well. Now we're going to talk about hypoxia, okay? Specifically, a state of oxygen deficiency sufficient to impair function. We'll talk about the 4 types: hypoxic, hypemic, stagnant, and histotoxic. Cardiac patients are typically affected by hypoxia. So basically, this is a result of insufficient oxygen available to the lungs. This can be due to a blocked airway, a drowning, or a reduction in partial pressure, such as we'll see at higher altitudes, which is how this applies to us in the flight industry. This is some examples of how lungs can be deprived of oxygen. Some medical examples are abnormal pulmonary function or respiratory obstruction. And typically, we're going to see, again, as altitudes greater than 10,000 feet. Now, this chart shows us that specifically as we start to increase in altitude, that barometric pressure becomes more dense, which is going to help to drop, which will actually not help to drop, excuse me, will drop the partial pressure of oxygen in arterial blood. So it's absolutely paramount that we oxygenate these patients, okay? Especially our patients who are bariatric, okay? They can develop bariatric burial trauma, which is nitrogen formation in the tissues and blood. Now, with hypemic hypoxia, It's a type of hypoxia that is a result of oxygen deficiency in the blood, rather than a lack of inhaled oxygen. It could be caused by a variety of factors such as anemia, blood loss, blood donations, which, by the way, if you donate blood on a regular basis, make sure that you don't fly within 72 hours before you take your next shift. Basically, hypemic means not enough blood. With stagnant is typically due to our G-forces. Basically, it's diminished availability of oxygen to the body tissues, and its causes are many and varied. It includes a deficiency of oxygen in the atmosphere as well. A good example of this would be a cardiac patient, maybe in cardiogenic shock, and we have a quick ascent or a quick descent. So we want to make sure that we're taking those ascents and descents very, very carefully so we don't have those negative G-forces affecting the blood flow in the circulatory system. So that would be simply me communicating with the patient, or communicating with the pilot that we're going to take gradual ascents and descents and so forth. Now, histotoxic hypoxia is the inability of cells to take up or utilize oxygen from the bloodstream, despite physiological normal delivery of oxygen to cells and tissues. And typically, we'll see this in toxins such as narcotics, phosphine gas, alcohol ingestion. The thing to remember about alcohol ingestion, there is a specific rule for the FAA and a CAMS rule for med crews that 8 hours bottle to throttle. Again, I'll say 8 hours bottle to throttle before you can get onto the aircraft after consuming alcoholic beverages. Okay, so signs and symptoms of hypoxia. Hypoxia can produce a multitude of effects, with the severity of the effects depending on the degree of hypoxia. So it's pertinent to remember that an understanding about hypoxia is vital, because its onset is very insidious, and there is no discomfort or pain brought about by the hypoxia. So we'll list some specific symptomology here in just a moment, both subjective and objective. Now, stages, let's talk. Before I talk about the stages, let me make sure that we understand, again, hypoxia is defined as a lack of oxygen, It's a real elementary principle that we all understand from our clinical training. So a lack of oxygen in the body tissues due to decreased quantity and molecular concentration. So in aviation, it occurs due to a fall in partial pressure of oxygen in the inspired air with the increasing altitude, and which is going to be beyond the human capability in the physiological component there. So now, as we talked about, all 4 stages of hypoxia may be encountered in flight. The most frequent and important type of hypoxia encountered in the aviation industry is hypoxic hypoxia. It's caused by breathing air at altitude, and the air is thin. The partial pressure of oxygen in the inspired air progressively reduces as compared to the breathing the air at sea level. So that said, that principal causes of accidental hypoxia in flight are ascent to altitude without supplemental oxygenation, cause some respiratory failure, or and so forth. So now, talking about the specific stages, the indifferent stage typically is not even compensatory at this point, and it's from sea level to 10,000 feet. Relatively safe without having to worry about this, but you typically, if this is the case, you want to make sure that you can descend as quickly as possible. Compensatory, simply put, compensatory action starts taking place at altitudes greater than 10 to 15,000 feet. So the body is going to attempt to protect itself. And so efficiency and performance of tasks, requiring molecular alertness will become impaired. Of course, the disturbance stage is a higher altitudes, which is hallmarked by dizziness, sleeplessness, or sleepiness, I should say. Of course, the thinking and muscle coordination becomes decreased. The critical stage is marked mental confusion, typically followed by unconsciousness within a few minutes. So the signs and symptoms here, as I said, we have a list of, you can read down the line here. Typical common ones: headache, hot, cold flashes, nausea, numbness, tingling, euphoria, combativeness or belligerence. And then, of course, what we can actually see is the unconscious state, mental confusion, loss of muscle coordination, impaired tasks performance, and compensatory actions taking place. Of course, oxygen use is to prevent hypoxia, right? So When to recognize the symptoms, as we mentioned, okay, monitor those patients for those symptoms in response to your oxygen and provide that supplemental oxygen and make sure you have backup sources and enough oxygen to take that mission. So check your main O2 cylinder and make sure it's 1,000 or above. If not, make sure that the trained personnel is refilling those cylinders and report that. Also make sure that you have plenty of backups and you have plenty of oxygen to take the mission, okay? Now, a time of useful consciousness, okay, is defined as the amount of time an individual is able to perform adequately in an oxygen deficient environment, okay? It's a period of time from the interruption of oxygen supply or exposure to an oxygen poor setting to the time when the useful function is lost, okay? Let me show you. It's not to be confused with the effective performance time, which is in a rapid decompression can reduce the time of useful consciousness by half. So let's talk about what we'll see is typically at higher altitudes, we're going to see that the time of useful consciousness has become very short, and considering the danger, the emphasis is on prevention rather than cure, which is true in most cases of just about anything. So with the time of useful consciousness, we're going to see as the higher the altitude increases with a rapid, sudden depressurization, which, well, it may not be rapid either, but so typically you're 12 to 20,000 feet, you may have a slow depressurization. And what we'll see is sudden, subtle changes in maybe your patient or your partner with as far as mental status is concerned. And then with a rapid depressurization, a lot of times we're going to see, specifically at those higher altitudes, fogging inside the aircraft and so forth, but not always, okay? As you see, the higher the altitude, the less time of useful consciousness that a individual has. Now we're going to talk about the self-imposed stressors, okay, using the acronym DEATH, which can lead to death. Funny how that works. Specifically drugs, okay, medication has two potential dangers to a safe flight. They can mask unsafe conditions, and then they can make the crew member feel unsafe. So make sure that if you're on specific prescription medications that you're able to operate at the level that you are therapeutic, all right? Of course, exhaustion can decrease in skill performance. Alcohol, remember 8 hours bottle to throttle. Tobacco, actually smoking cigarette tobacco actually can decrease the peripheral vision due to carbon monoxide causing that hypoxia relatively at 4,000 feet over a period of time. Okay, of course, hydration. I want to make sure that we're hydrated, and dehydration can increase the risk of hypoxia, all right? Remember, there's going to be a decreased availability of moisture, which is going to cause some inflammation and decrease efficiency of gas exchange. Remember that, you know, the temperature will drop 2 degrees Celsius for every 1,000 feet that we climb, okay? Now we're going to talk about body systems and flight physiology and some things to be mindful of here as it affects of course we can see here, of course, our hollow organs would be typically affected by which specific law? Right, Boyle's law, okay? Remember, because as altitude increases, the gases are going to expand, and as altitude decreases, the gases are going to contract. So we'll specifically see this true in the respiratory system with the hollow organs, okay? Specifically, if we suspect a patient to have just a simple pneumo, we want to make sure that we evaluated that pneumo, what percent that pneumo is, and if it's greater than 15 to 20%, we want to make sure that we have at least put in a chest tube prior to departure. Okay, that is a skill set that we're able to perform, and you will be trained on that skill. You know, an existing pneumothorax left untreated can expand and cause lead to a tension there. All right, and of course, causing the vascular compromises as well, and the circulatory component. Of course, COPD due to the dry air, dehydration due to the cold, dry air. We're going to be mindful of that they're being well oxygenated. Even oxygenation can cause dryness and coolness. So if you have humidified oxygen available, that might be something to consider. Of course, pulmonary edema, okay, is going to cause some vasoconstriction. It's going to cause that hypoxia, which can really lead to that reflex dilation. So the patient becomes hemodynamically unstable. Another thing that we want to make sure that we have the ET tube cuff with the ET tube cuff cufflator attached if the patient is intubated, okay? Now, the central nervous system, typically we're going to see compensatory actions taking place due to positive and negative inotropic effects. In the parasympathetic in the sympathetic and parasympathetic nervous system. And this may be due to the frequency of the flight, the duration of the flight, noise, vibration, and so forth. It can affect both patient and clinician. Of course, the vasculature, okay, is compensatory actions that can cause some vasoconstriction, okay? Or want to be mindful of coronary vasodilation as well when we're talking about specific disease processes. And I'll talk more about that as we are loading a patient or ascending and descending. Of course, pulmonary as well, compensatory constriction or dilation. Typically, the signs and symptoms with the central nervous system, you'll see some hyperactivity and impaired judgment. All right, with disorientation, basically they're just unable to account direction, location, may result from a prolonged transport, fatigue. Night flying typically can cause these type of issues. Maybe extreme aircraft maneuvers due to specific, maybe emergency at hand, okay? Specifically, disorientation on that aspect is spatial disorientation. Basically, this occurs in the vestibular canal and the semicircular canal in the ear, okay? That most severe vestibular illusion occurs when the semicircular canal fluid flows in two planes of rotation simultaneously. Okay, the aircraft may feel like it's turning. They can cause this by rapid head movements and so forth. Gives the clinician or maybe the partner, or excuse me, the other clinician a false sense of spinning or climbing. Okay, typically the correct to this is the relax. Let's try to allow the sensation to subside. Don't panic. Again, keep away from the sudden head movements, and the pilots will rely on their instruments, okay? Now with the GI system, one thing to remember about the GI system, again, will be affected by the aspects of Boyle's law, specific hypoxia such as stagnant due to G forces, patients with ischemic bowel syndrome, or patients with pancreatitis, sequestered bowel. They're all going to deal with some sort of issue due to the natural gas law of Boyle. So we want to make sure that we're communicating to our pilot very effectively. In such the case with rapid ascents, just normal rapid ascents, this can cause quickly that Boyle's law to take place, causing some pain, some discomfort, or maybe even hemodynamic compromise. Okay, so we want to make sure that we're communicating to our pilot that we want gradual ascents with these types of conditions. Make sure that all gastric tubes are in place and vented. A lot of the manufacturers of gastric tubes, specifically NG, already have the open ports. Okay. Again, we may have to descend to a higher pressure. On a clinical standpoint, as a crew member, watch what you're eating before you go. Okay, a Coke and a cabbage will not be ideal. All right. Of course, in the bladder, okay, it retains some gas as well, which would cause that expansion. So we're going to make sure that we're going to put a Foley in place if appropriate. With the pregnancy, okay, typically we're going to make sure, remember that it's an oxygen deficient environment anyways. So typically a lot of the times the fetus is going to be suffering from some sort of oxygen compromise. So we'll make sure we're providing supplemental oxygen, okay. There may be increased fetal stimulation due to the increased uterine stimulation due to vibration and noise. Contractions may start to precipitate, so be mindful of that. So appropriate positioning and inform pilots of landing considerations. Maybe we're not able to make it to the nearest appropriate facility and we need to make another landing. So those are the types of things that we want to make sure that we're communicating with the pilot. Now with the middle ear can cause some disorientation due to being able to clear the ear or pain and so forth. So equalization of pressure does not occur automatically during ascent. So with ascent, pressure is going to decrease and gas is going to expand with the middle ear. During descent, the ambient pressure rises above that inside and the eardrum is forced inward. So how that works is that eustachian tube in the ear performs as a flutter valve and allows that gas to pass outwardly, but resists the reverse, okay? So with the ear block, the Barrettitis media, okay, typically factors are flying with a head coat. Don't fly with a head coat. If you're sick, don't come to work, okay? You'll earn paid time off. Flying with a sore throat, sinusitis, tonsillitis, things of those types of inflammation. You want to stay ahead of your ears, okay? Maybe need to do the Valsalva maneuver during descent, such as doing that aspect there. When you possibly use self-medications with vasoconstrictors, but want to use those with caution because they may have rebound effects, such as those nasal sprays, the neosynephrenes, that may not allow that swelling to subside. So for treatment, yawning or swallowing, again, that Valsalva maneuver, extremes for maybe the patient standpoint, pain medications, for a patient, for infants and children, bearing down again, blowing through a straw. The best treatment, though, is to ascend to a safe altitude where symptoms subside and then slowly descend as appropriate. Now, Barrett's sinusitis, the sinus block, okay? Basically, it's acute inflammation in the paranasal sinuses, okay? So a lot of parallels to the ear block there. So again, this is all due to Boyle's law. As gases expand, okay, it's going to cause also those other components in the hollow areas to expand as well, which is going to push and cause those pressures. And a lot of times it'll be common colds such as the upper and respiratory tract infections, maybe a feeling of fullness around the sinuses, which can cause excruciating pain. The best treatment is to ascend to a safe altitude and then take a slow descent. Again, sometimes that Valsalva maneuver may be effective, but it just depends on the altitude as well. All right. So barytontalgia, the teeth. Okay. If you're having any dental work, be sure that you do not fly 72 hours post dental treatment. Due to Boyle's law, again, this can cause expansion and cause excruciating pain into the tooth canal there. So it commonly occurs on ascent because of that Boyle's law, and typically, for the most part, depending on the altitude, may feel relief on the descent aspect. Okay. Decompression sickness, really that has to do with nitrogen in the tissues there. I want to make sure that, you understand that the lungs are going to decompress faster, unfortunately, than the cabin. So hypoxia risk is dependent upon altitude. So remember that when the atmospheric pressure is decreased rapidly to critical values, that nitrogen pressure gradient between the body and the outside air will form nitrogen bubbles and can occur in the blood, other fluids, and even in the tissues. So oxygen, oxygen, oxygen. Make sure that if there's any clamped tubes, you unclamp them so we don't cause that stagnation with the nitrogen there. Secure yourself and the others, and then, of course, descend. Dehydration is always a risk factor in increasing altitude because of the close ventilation system of the aircraft is going to decrease that humidity, causing that dehydration. And even in higher altitudes, the air is dry naturally as it is. So, and that can result in sore throats, chapped lips, and so forth, and even further systemic dehydration. So when monitoring the patient, if it's available, humidified oxygen. Burn patients have several comorbidities. They're exposed to infection, hypothermia, and dehydration, so monitor those appropriately as well. Okay, some thermal considerations. As I mentioned earlier, the atmospheric temperature decreases 2 degrees for every 1,000 feet increase in altitude. It's cold. It's cold as you ascend, okay? So make sure we're providing adequate warmth to the patient. Of course, exposure to whole body vibrations appears to interfere with humans' normal cooling response in a hot environment as well. Trauma patients, the things we remember with trauma patients, specifically in a hemodynamic patient, a hemodynamically unstable patient, maybe the patient has some inadequate preload or something of that nature due to multi-systems trauma. So we want to make sure that we're talking again, communicating with our pilot, that we take so when you think about it, as we start to take a normal ascent, right, think about where the patient's head is and their feet. Basically, in a nutshell, we're standing them up on their head. We're standing them straight up on their feet. So if they're hemodynamically unstable and we've got marginal pressures, pressors trying to obtain marginal blood pressures, the rate of ascent can affect that greatly due to the G-forces. So communication to the pilot would be gradual ascent, please, okay? Talk about when we're talking about bone fractures and so forth, we want to make sure that they're splinted so we can avoid that vibration. And pregnant patients, as we mentioned earlier, positioning, oxygenation, and fluids as appropriate depending on condition. If they're preeclamptic, obviously fluids would not be indicated at a high rate, okay? Burn patients, again, have high comorbidities. They suffer from infection, they suffer from hypothermia, they suffer from dehydration as well. So we'll make sure they're adequately hydrated, that they're, we're providing plenty of warmth, okay? A lot of times, again, they become hemodynamically unstable as well. So we'll make sure we're using our appropriate burn fluid resuscitation formulas. Right now, we're currently using the Parkman burn formula as well, okay, where it's 4 times the total burn percent surface area, 4 times the total burn percent area, and the patient's weight in kilograms. So also, we want to make sure that we're using that rate appropriately and utilizing that rate dependent if the patient received fluid resuscitation already. Okay, it's not just an automatic start over. With the trauma patients, and we talked about the gradual ascent, okay, we need to talk about the gradual descent. Because remember, now that we're descending, we're standing the patient up on the side of their head. So if they have an increase in intracranial pressure, that's going to cause a flight physiological problem if we're not communicating to our pilot with that, okay? So also it'll occur during ascent as well, in ascent as well. So performing frequent neuro exams, okay? Remember, the most important aspect of a neuro patient is the cerebral perfusion pressure, and we can get that with the ICP minus the mean arterial pressure. As a review, that remember that the ICP has a normal value of 0 to 10. If we don't know the normal IC value, check the GCS of the patient. That might give us a rough estimate. If they're altered, okay, it might have an increase in that. ICP is greater than 10 is usually bad. Can I say it again? Bad. Okay, and then with your mean arterial pressure, in that formula is simply the mean arterial pressure is the diastolic times 2 diastolic times 2 plus the systolic divided by 3, and that's how you calculate that formula to give you adequate cerebral perfusion pressures. Anything less than 70 is bad, okay? Again, concerning our trauma patients, some miscellaneous items such as the barial trauma, as I mentioned, these obese patients. They need high concentrations of oxygen to wash out the nitrogen, okay? These patients will present with, most of these patients in trauma, pain, compensatory actions, paleness. Those are some things to watch for. Shock considerations, remember patient positioning on ascent and descent for the gravitational forces that are at play. Other considerations, noise. Of course, noise interferes with the evaluation of breath sounds. This is why good capnography would be good, just to see if you're getting a good end-tidal CO2 reading there. Of course, the auscultation of blood pressure may be difficult, so maybe having to palpate at times if the automated blood pressure cuffs are not working. And specifically on that, it may be good to have an arterial line in place to monitor a real-time blood pressure depending on the hemodynamic status and diagnosis. And arterial lines is something that we train and have in our scope. Okay, of course, vibration, the frequency, intensity, and time can also cause a self-imposed stress, or a non-self-imposed stress. Of course, now prevention, going to anticipate the effects of stress of flight prior to transport. So if you had tooth work, if you had blood donations, if you drink a Coke and a cabbage, if you're a smoker, okay, I want to make sure that you don't give those self-imposed stressors there. Avoid gas-producing products and producing foods, okay. Don't fly when you're sick. And monitor your wellness and being, and be mission ready due to the harshness at times of the physiological aspects of flight. Okay, this will conclude the PowerPoint presentation on flight physiology. Please proceed to take the exam following this PowerPoint. And thank you for watching.